let's maybe say a few words about the indications of toric lenses. I'm not talking about multifocal or EDOF, pure toric lenses in irregular astigmatism. How do we manage that in terms of indication, and what are the criteria to say, okay, it's irregular, but there is a place for toric implantation?
I must say I'm conservative, so I've been burnt a few times by putting a toric lens in a patient with irregular astigmatism. I think one aspect is if you have a patient who was post-PK, the PK will, for all we know, survive this patient until the end of his days, and we think and it has been very constant over many years. I think that's an indication. There's no question about that for the regular component. But for patients, for example, with keratoconus, I've stopped doing that. But again, maybe also I just have too little experience with that.
What about piggyback implantation in these cases?
We use Toric IOLs in the lower grades of keratoconus, but you have to look very carefully into the history. If they were, glass wearers in the past and have been, and not rigid cast permeable wearers, because those, that can give you information on the grade also. And then, well, we look at the best corrected vision that they were able to achieve before they get cataract, actually. And that's one of our measures that we take into the equation, if somebody is suitable to do that, yes or no. And if you have low grades, I think it can be very, very good solution, actually. But you have to be very careful that you don't going to implant them in
very
those
important
cases.
also too.
And not fully correct as well.
And not fully correct, you have to aim for some residual myopia, because it can bring you into problems, of course, with the fitting process of contact lens is still necessary afterwards. You can get into problems to do that.
Very important also, I guess, to compare what you're getting in terms of amplitude of astigmatism and the axis with the different machine, because it needs to be corrected, otherwise it's a coma which is the dominant portion of the aberration and not the cylinder, I guess.
Yeah, but you have keratoconus is a really, is a difficult topic, because you can have low grades of astigmatism, you can really high grades of astigmatism. One thing I think is important, you have to make sure if you do toric lenses that you have a stable cornea. So very often I found ourselves to do cross-linking before for the whole thing, if this is an indication. And then I also like the concept more and more that we put a lens in the capsular bag and a piggyback toric on top of it in cycles, because then you have the opportunity to change. It's easy to exchange these lenses, and we know that conus eyes can change, and maybe you, as Oliver said, you maybe have to do a keratoplasty and a penetrate. So it's a difficult topic, but I think if you have the right selection, patients can really benefit from this.
There are patients who come in who never knew that they had keratoconus and were perfectly corrected for the rest of their life. So I don't see a reason why you shouldn't put a Toric IOL in these patients that are already 65, 70, 75 years old.
On the other hand, some of them have an extremely good depth of field or depth of focus. So that means some of these patients, they've never worn glasses. Yeah. They don't see well in any of the distances, but they see
aberrations.
Yeah. So in a certain way, I would, these sort of subclinical cases, from Frust, if you want, I would probably try to leave the cornea and not touch it or change it with a toric lens if you want, indirectly. And the piggyback, I've been burned a few times by rotating toric lenses, which rotated many, many weeks and months after surgery. I know you can then suture them, but patients, so I think I'm not really happy with the toric piggyback lenses, I must admit.
No.
Yeah, but I think that in these cases, potentially, if you have to do it, they are prone to really do a little suture on the iris and then basically have to do it once. So I think that's a good surgical option. You can do it, but I agree, they can rotate. And this is a very special situation with keratoconus.
So let's remain in the field of special indications. There is one which is really going to increase, which is the indications and the discussion of presbyopic IOLs after refractive surgery.